discussion. So if you are a panelist, you can come on up and take your seat up here on the stage. All right, so thank you to all our panelists for being here tonight. If we could just start with introductions, just say your name, the organization representing, and just a brief overview of what your organization does.
I am Casey Cowie. I'm a family physician and the chief medical officer at the Summit Community Care Clinic. The care clinic is a community health center, and so we provide primary care, behavioral health, and dental. And we're located in Frisco, our main clinic. We have 7 school-based health clinics as well, and a clinic in Lake County. And so expand on that more.
Hi, I'm Dana DeHerrera Smith. I am the Director of Community Engagement and Development for Porchlight Health Front Range Clinic. And we provide medications for addiction treatment, all FDA approved medications for addiction treatment except for methadone. We also provide behavioral health services as well as Hep C and treatment and prevention for HIV. And I am missing one, psychiatric services.
My name is Scott Rodriguez. I work with Mile High Behavioral Health. I am also a peer and high fidelity specialist. Basically, all that means is I work with people that were once in active addiction or still currently in addiction. I also work with families with kids that are in dual services. So it could be probation, it could be referrals from departments of public health or anything like that. So what we do, we also offer 4 pillars. So we do a lot of we do some mat services with Porchlight. We also offer LGBT plus free care, as well as peer services and therapy for any kind of whether it be substance abuse or anything like that. So
I'm Lori Spurgeon. I'm officially the Assistant Director for Denver Recovery Group. I'm also the Director of Clinical Operations, the Outreach Coordinator, and a billing liaison with our billing department. We do. Anything else?
Looking for the raise.
Okay. We provide MAT. It is for adults 18. There's no limit. We are able to work with people under 18 as appropriate. There are some things that we need to ensure are in place, previous treatment attempts, time in treatment. They are able to get other medications than methadone through a primary care provider. And so we typically, depending on age, will refer them back to a primary care provider and help coordinate those services with them and their families as well. And you've heard enough about us.
Hey y'all, I'm Maggie Saldine, still the founder and director of High Rockies Harm Reduction, but a little bit more info about us. So these are the services that we provide. Right now we're doing monthly mobile pop-up services. Unfortunately, we won't be here in August because they're having an event, but we've been doing our services here at CMC Breck, which is really exciting. And again, we have 9 locations right now across 5 counties. Where we do, it used to be called syringe services, but we do a lot more than that. So I don't even like that terminology. We have safe snorting, safe smoking to reduce the spread of disease. We have syringe disposal, and we're one of the only organizations that actively incorporates recovery and harm reduction and providing those services together. I think that that's what everyone does, but we're one of the few that says it.
All right, well, thank you for those introductions. I'll start with one question that we got from a community member. This has to do with mat services. Question reads, it seems like this is switching one drug for another versus getting off drugs altogether, which seems like should be the goal. How does that work?
That's one of those myths that was on our list. We're trading one drug for another. And again, methadone is a medication. It's a synthetic opiate. It's not something that someone can take and get high. So not trading a high for a high. They're trading a high for stabilization. And so we really promote that they come in to the clinic, they go up slowly on the medication to ensure that they don't get over sedated. And again, sometimes we have to back off and readjust. But it is not the same as injecting heroin or taking a pill, and people who have met here today and spoke with you can attest to that as well. And so that is just simply one of the myths that keeps people out of treatment, unfortunately. And it keeps their family away from them a lot of times because that's what the family believes. And again, with the groups that we provide in education with the patients, how do you talk to your loved ones and your family members to know the work that you're doing and the medication that you're taking to support your stability and to decrease, eliminate withdrawal symptoms and cravings. Heroin is not going to do that for you, and neither is fentanyl.
Sorry, Lori, I had to interject here.
And who are you?
My name's Anthony Lonzo, I'm the CEO of Denver Recovery. You're not trading a drug for another drug. It's an oversimplification. Yeah, it's a drug for another drug, but when you take methadone, you know what you're taking. I don't think anybody on the street buying drugs, finding drugs, whatever, knows what they're taking. Or we wouldn't have 100,000 people dying every year. This fentanyl is bad and getting worse. And they're putting it in everything. But if you come to our clinic and you get on the program, and you get on methadone or Suboxone or whatever we're gonna put you on, we know what we're giving you. We know when we're giving it to you, and we know how much we're giving you. We know what's in it. You're getting therapy, you're doing groups. It's harm reduction in the truest sense. I remember when I was young and I still had knees and I was able to ski. And I took a skiing lesson up here. And the instructor said to me, do you want to go down modals? And I said, no, I don't want to do that. My knees don't. He says, yeah, I tell people all the time, there's no such thing as an old modal skier. Well, I don't think there's any such thing as an old heroin user. Nowadays with fentanyl, it's getting worse and worse and more dangerous. And we're trying to save people's lives. So if I can get you off something that you don't know what's in it, you don't know what it is and what you're taking, onto something that's not going to hurt you, and we're keeping you alive, and that is harm reduction in the truest sense.
Sorry, Lori, just one more thing to add since you had the mic. We get that question a lot, and we welcome that question because one of the things that we encourage is kind of a shift in thinking that this is a disease. It's a brain disease that has created multiple millions of these opiate receptors on the brain. Methadone helps to heal those so that they close and that their tolerance can go down. But if you really think about it, when somebody comes to us, they have died maybe 2, 3, and we're lucky that they're back at our clinics, similar to somebody who's had multiple heart attacks. And never in a million years would anyone ask somebody, Dad, when are you going to get off that Coumadin? Because I'm really concerned. Why aren't you getting off everything? Because I know you can do it. If we know something is working, why would we ask them to change it? It takes years for people to change the behaviors, mental health, the medical conditions that we discover, for them to get fully stable in their life. If they want to taper, we will help them taper. We'll do it in the most functional way that we can, but we definitely try to encourage maintenance for the simple fact that we know simply having that medication in their brain on their receptors makes them so much less likely to die when they do relapse. And we know also that this is a chronic relapsing disease. I don't think we've ever had a patient, no matter how long they've been with us, not relapse. And the longer you're in treatment, the farther you are away from the opioid, the closer you are to death with a relapse. That's one piece people don't understand. That's why when people get out of jail after 30 days of being sober, they relapse one time and then they overdose and die, because those receptors have closed down, their tolerance has decreased. And so that's what methadone does. It helps patients stay alive.
I just also really quickly want to add, even though I'm the least map provider up here, but, you know, there's all this stigma around using drugs, but I mean, we heard a story already tonight that illustrates that the majority of opioid addiction starts with prescribed medication for pain. We are not good at treating pain because it's a subjective reality, and that's how we got in this problem, is trying as a society to figure out how to treat pain. And the reality is that most pain patients, especially seniors, don't have any other options but to use opioids. And then they get cut off the moment we become addicted, but it's dependence. I mean, it's so many beautiful things just said that, you know, this is very similar to any other chronic illness and similar chemical dependencies like insulin. And the way that we talk about drugs is kind of wild because it means a lot of things to a lot of different people, but this is pain medication that we're talking about.
I don't necessarily have a question, I would just like, maybe the people from the mountain communities to speak to, so I've lived in Summit County for about 28 years, I'm an acupuncturist. And certainly thank you for the point of we're treating pain, you know, here, and, you know, I think that in the mountain communities and cities, maybe there's more accessibility to community clinics for acupuncture, things like that. Not so much a reality or possibility as such in the mountains. But living here for nearly 30 years, both of us actually here, you know, I've seen drug use and treatment and issues evolve in, you know, lots of ways. And I just kind of would like people from the mountain communities to speak to what you've seen with that evolution, what you think has worked, what hasn't worked, what the future might look like, that sort of thing. With treatment?
Yeah, I think that's a great question. It's definitely evolved over time. I've been at the care clinic now, for 12 years. And when I first started, MAT wasn't even a thing, or at least not that we had heard of. And I remember when I had first started into this position, as the director, someone coming up and asking, like, do you think you're ready to start an MAT program? It's like, oh my gosh, no. Like, so it's evolved so much so that now medication assisted treatment is part of primary care in our practice. And so you can come in and see your primary care provider and they can treat your diabetes and they can treat your toenail fungus and they can treat your opioid use disorder, you know. So it's evolved so much to the point that just last 2 weeks ago, I had a new patient who had moved here from out of state. He had some sleep apnea, he had some insomnia. We got him connected with a behavioral health provider, and then he kind of looking down was very, you know, I'm embarrassed to talk about this, but you know, I had this happen and I was using opioids and then I got on Suboxone. I'm doing good, I'm really good, but I need somewhere to go to get treatment. And I said, well, I can do that. So, and that's become the norm now. So that's such a big evolution over time that now primary care providers, not just in our clinic, but many clinics, but all of our providers can treat patients all the way around. So we can treat you for all the things and it's just part of you. And like you guys were talking about that it's a chronic disease. So a primary care provider should be able to treat chronic disease. And so that's now, that stigma has really decreased in a very short period of time. And so I'm really happy to see that.
I'm not from a mountain community, so full disclosure. However, we have over 60 points of care and about 20% of them are in mountain communities. And I am from a rural community, so I feel like I can speak somewhat to this. And I will say one of the things, and I'm gonna pivot real hard here. So one of the things I feel like that I've really seen in our mountain communities is that there is a greater need for alcohol use disorder treatment and stimulant use disorder treatment. And I think that's a really big thing. Obviously fentanyl is killing people, right? And opioids are killing people and we are seeing that every day. And I'm constantly trying to remind folks that opioids are not the only issue that we face. And I think, you know, we hear a lot of times that the mountain communities are drinking towns with a skiing problem, right? Like, and that's just kind of the joke, and we just, you know, that's what we say, but it's a really big concern too, right? And so I think as we continue to have these conversations and make access to care to, I'm echoing. As we make access to care for opioid use disorder treatment, we cannot forget stimulant use as well as alcohol use disorder. Because those are just as big of an issue. It's killing just as many people, if not more. And there are treatment options for that as well. And I think part of that is, and I think Summit County's done a really good job of that, right? Their Booze Less campaign through Building Hope. I think they've done a lot of work to really highlight that you can have poor relationships with alcohol without necessarily being considered a quote unquote alcoholic. And just having, I think there's a lot of room for evolution in those conversations and challenging the norms of these communities of being that drinking town with the skiing problem, right? And really being able to create sober spaces or spaces where alcohol is not the primary focus of these events. Being able to speak to, yes, you know, you may not know anybody who's died of an opioid use disorder, but you may have 5 friends who died from drinking, whether that's driving and drinking or, you know, long-term use of alcohol. And so I think that's just something in our mountain communities that we really need to be cognizant of, because I think, in my opinion, that seems to be a more prevalent issue in mountain communities. But the death isn't as advertised, right? And there's a lot of norming to alcohol use. And it's societally accepted, right? Nobody judges you if you say, hey, I went home and I drank a bottle of wine after work today. But you would have some feelings if I said I went home and I slammed 2 syringes last night, right? And like that is an inherent, I think, piece that we need to talk about is we should have that conversation. If you have a friend who tells you every night that they're going home and drinking a bottle of wine, you may want to say, like, friend, are you cool? You good? Do you need some support? Like, can we help you with that? Do you want to talk about it? Because somebody said, right, it's a symptom. Substance use is a symptom. It's not necessarily the problem. And I think we just need to remember and recognize those other substances that we have at play, because they are just as impactful.
With what she shared, I'd like to share what happened when we opened our Montrose Clinic, a mountain town, pretty close to here, but not really. We had patients walking in the door, 2s and 5s, and family members of 3s and 4s, coming in and saying, well, I don't use opiates, but something's wrong with my meth. And there was a lot of methamphetamine in that area. And so the primary thing that we treat is opiate use disorder. So we can't bring someone into treatment because they're a methamphetamine user. We have to have a primary diagnosis of OUD, opiate use disorder. We do treat the polysubstance use. And so we would say, okay, literally around the corner, walk to the crisis center, go in and talk to them. They'll do a UA. Every single person that walked around the corner came back and they were positive for fentanyl. They were all being poisoned with their parent drug of choice with fentanyl. And so we're getting them to treatment. And with what you had shared about other modalities of treatment, we also cannot prescribe methadone for pain. Methadone can be used at a pain clinic or through other physicians as a pain management option. We cannot provide it for pain. But what we can do is help connect people in the community who do acupuncture, massage therapy, EMDR, other trauma services to really link together and provide whole human support. And so anyone here who has those services, we would love to connect with you. So we have referrals for our patients who still struggle with severe pain, who still struggle with other substances. Alcohol, like you were saying, cannot be ignored. It lets go of all the I cares, right? It puts people in a position where that goes away and other things come on board. And so I just want to share what happened in Montrose, because we weren't sure what that was going to look like when we went there. We knew they had issues with addiction. We knew that the community was needing help. And now we are pretty stable with 85 patients. We've had 250 patients walk through the door. Some of them were traveling through and going somewhere else. Some of them were coming to visit family or going to Telluride to ski for season. And so they're with a short period, and not everyone stays and maintains treatment, but they're always welcome back if they leave. And that was our experience there. It was really eye-opening to what the community was experiencing with the severe issue of methamphetamine. And so we've gotten to bring them in, being someone who needed to be on medication for opiate use disorder, as we help treat their methamphetamine addiction, as we help treat their alcoholism, get them back to their primary care for an abuse, right? And so there's a lot of things that we cannot provide those supports, but we really want to help them to get the right level of care with whatever it is they're struggling with.
I was just gonna close out is that pretty much I'm 10 years sober and my choice is uppers, you know? And not everyone, some people can drink. I can go have a drink once a year and just fine. But some people out there really can't have a drink because it'll be 20 drinks later. And what we're seeing in this like community since we've had harm reduction, I've seen more of my friends' life saves than before. And fentanyl is just killing people. So I'd rather have people test their drugs than not test their drugs. And there are more things coming out to like make sure there isn't fentanyl. Like there's machines coming out and other stuff coming out that I'm learning about. So harm reduction will save your children's lives. It's very important in this community. Thank you.
Thanks, Sonia.
The number one qualifier for access to treatment is that you have to be alive, right? Dead users don't recover. And that's what harm reduction does, right? It bridges the gap.
Sorry, thank you. And yeah, thank you so much for that, Sonia. And that's like, you know, our lost loved ones, they may have not been in the best states when we lost them, and they didn't have the chance to be their best selves. They didn't have access to the resources that we have. And I think to answer the, you know, mountain question, and this is kind of echoing a little bit what was already said, but 20 years ago, you had to drive to Denver for Suboxone. 10 years ago, you know, you still had to travel to Denver or Grand Junction for methadone, Suboxone, syringes, all of these services that now exist. And in addition, with alcohol still being a huge problem, and I always say too, like with harm reduction, like alcohol leads you to doing worse things. And that's like, not that cannabis doesn't have its risks, but like you're more likely to lay on the couch and eat too much food than you are to like grab your keys and go buy a bag. With alcohol, where those inhibitions are lowered and your motivation and drive is still high. So we're seeing more outpatient treatment providers and things like that opening up for people, because we're seeing that it's really hard for people to go away for 30, 60, 90 days, leave their community in most situations, right? But we're seeing more rehabs, we're seeing more treatment centers, more outpatient, inpatient, sober houses, recovery groups, like everything. And I think those big three things, to have Suboxone in our community, to have methadone in our community, and to have clean syringes. I honestly can't even believe that I get to be a part of that list, because these are the things that save lives. And it's hard because it's still very difficult to always get people to come out for the services. It's hard for people who need these services to come out and get them because they're afraid their neighbors are gonna see them, you know, people from church are gonna see them, whatever the case may be. There's still a lot of stigma. And so like 85 to 250, like I wonder how many people in Montrose could really benefit. And you know, like we see it a lot of our things, like this affects our community so intensely, and it's still hard. And one issue to get people to come out, and one issue I face is, you know, we're still rural, and the smaller the towns, sometimes the worse the problem is. So it's great that we're doing more in our bigger rural towns, but like we're trying so hard to get out to the smaller communities. And I mean, I've even done a lot of like home-based services, because that's not like the best model, because I'm only me and I can't go to everyone's house, but it's hard to really meet the unique needs of rural communities. But I will tell you, from all of the county, I basically serve like all rural counties in Colorado in some capacity, and Summit is killing it. Like it is really, really impressive to me, and it's public health, it's law enforcement, and it's all these amazing people doing this amazing work. I really think we're here in Summit, we're the front runners in this. So there's still always improvement to be made, but we've come a long way.
We have a text in question. The question is, how do you start a conversation with someone when you're concerned about their substance use and want to get them to get help? And Scott, I'm actually gonna put you on the spotlight here, because I asked you this question not too long ago, and I really appreciate your answer, so.
Yeah, so I think the biggest thing as far as talking to your loved one is coming to them out of a place of compassion. When you use words like, you know, aren't I good enough? Don't you love me? Don't you love your kids? Things like that. That's already putting shame on somebody that's already dealing with a whole lot of shame, right? You don't go into drug addiction or substance use disorder, saying, you know, I want to end up like this, you know, I want to end up like a quote unquote junkie, right? So being able to come to a place of curiosity and compassion, I think is a big part. And meeting them where they're at, you know, whether they're still using or not, they're still people, right? They're still your loved ones, they're still people that you care about. And when you start putting labels on people and you start saying, you know, they'll never change, they'll never be, you know, the person that they envision them to be, it's just more shame added to that, right? So the more that we can get out of that label, the more that we can get out of that perception of whoever it is, loved ones or not, the better they're gonna be when they decide to get recovery or seek out help.
Shame equals stuck.
Yeah, I mean, the biggest thing with addiction is connection, right? So if you're connected to somebody, they're more likely to try and turn things around, so, yeah.
There are also some options funded by the state. So the state of Colorado offers, there's several providers that offer it. We're one of them. I think you guys offer craft groups, maybe, yeah. They're called craft groups. Could not tell you what the acronym means. I will mess it up every single time. But the groups are specifically intended for loved ones of people with substance use disorder that talks about, you know, how do we set boundaries? How do we show compassion? How do we navigate what is sometimes a really complex treatment environment? And so I often recommend that. It is free to anybody in the state. And so I think that's a really good place to start. It's curriculum based and gives people some options for how do I navigate this with somebody I love.
There's also CODA, and there's a lot of online meetings now that didn't exist 10 years ago, 20 years ago. And it's an online support for family members and people affected to meet with other people and other family members and loved ones who people struggling in their life with addiction. And so that's another opportunity to meet with like-minded folks who want to have those conversations and learn more about what their loved ones are going through and how to have those conversations. And so that's just another opportunity.
There's another question out here.
I was just wondering, is there a sober living home up here? We don't have one yet, do we?
I would say, not that I'm aware of, that we've looked into. As far as I'm aware, there's not a lot of support for the homeless population in this area. Speaking to some people in the community, they help them get to Denver.
That's it, yeah.
So they cannot be here, and it's too dangerous for them to be here in the winter months, so they help them get to Denver. But they haven't had anything in this community to provide them support here in their community.
And I would say part of that is like real estate issues and housing, you all know. And because Oxford House is like one of the bigger sober living homes. And I do think that they did finally, like they're moving outward and inward, but it's hard, like the size of house that they need. I mean, these are like $3-4 million homes in our communities now. I will also say that I've noticed that there are a lot of like mutual aid houses that exist that like nobody knows, like I don't know for sure if there are here because I found out about them in like the town that I live in and other neighboring towns were like, I don't know where you would find out about this if you weren't like in the AA circles and in the know, because they're really just like roommate situations where it's very much like boots on the ground peer support, like they're not tied to anybody or anything except each other. And you'll hear like about this house or about that house, but if you're not like in the know, which is annoying because we need these resources. So I'll have to do some more research on that because sometimes we find out about like weird little things that are going on underground.
Well, I'll go with one of the questions that we prepared here. So it sounds like there's been great advances in the resources for us here in our High Rocky community. So how do I know where to go for treatment? How do I know what treatment is right for me?
Well, if you walk through our door, we can help find it. We do screen people who come to us for help, and not everyone's appropriate for our level of care. And so if they're not appropriate for our level of care, we do help really do that case management and provide services to help find what is available in the community. Whether it is for mental health, methamphetamine addiction. Sometimes people come into us and they need to go to a detox first. You can also go through the emergency department and try to connect with the hospital and their social workers at the hospitals. But I'm not aware of any other services here, except for, the people who brought us all together. I know that they work diligently to find treatment for people and connect people in the community for care.
Just wanted to add one piece about the medication. There's 3 distinct differences between the medication, and it's about when you enter treatment. In order to get on Vivitrol, you have to have about 4 to 7 days of sobriety before you can start the medication. A lot of patients really can't get to that 4 to 7 days without like an inpatient detox or a hospital stay, or quite possibly a residential stay of some sort, or incarceration. So those are the great entry points for that medication. Suboxone, you need at least 48 hours. Some doctors will, if you're in a hospital setting, will initiate you at 24 hours. Because if you start Suboxone sooner than that, it will start the precipitated withdrawal. So again, unless you can go to a detox or you're in a hospital, some patients can't get to that 48 hours on an outpatient basis. But with methadone, you can start right away. Our patients literally they'll smoke their last, fentanyl, they're blue, walk right in, start in methadone as soon as we finish the intake. So those are important things about how soon the patient really, if they can get off opiates without any assistance.
I would really say that we look at voice and choice as well. For a lot of the people that we work with, maybe they're not ready to even start treatment, right? But we meet them where they're at. Whether that's still actively using or thinking about stopping or whatever the case is, we want to make sure that whatever options that we're providing for these people are going to be something that they're going to be able to stick to and that they want to stick to. A lot of times when you put people in places and situations where they're forced to do something, they do it maybe for a little bit, for a little while, for a couple of weeks, for probation, whatever the case is. Next thing you know, they're either relapsed or something worse. So we try to make sure that, whatever avenue we're going to or going through, it's up to that person, and ultimately they're the ones that are be doing the work.
I think peers are a really good place to start when looking for care as well. Because to that point, voices and choices, right? Not everybody's gonna love DRG, not everybody's gonna love Porch Light Health, and they still deserve access to care. People may fail one of the programs or not be successful in one of the programs, and they still deserve access to care, right? And so I think peers are really important to helping navigating the treatment systems that exist. Helping navigate what are you looking for? Are you looking for a reduction of your use? Are you looking for full abstinence? Are you in a position where you are ready to engage in behavioral health and really want that component? Or are you literally just trying to get your feet under you so you can go to work tomorrow, right? And so I think there's a lot of options here. And being able to find things that work. And I tell people all the time, if this doesn't work for you, keep trying, right? Just because this treatment program didn't work for you doesn't mean that treatment isn't for you. And so I think that's a really important piece to remember. I'll add one little thing for folks with alcohol use disorder. Vivitrol can be started right away. So that abstinence piece is specific to opioid use. There are also some methods being used to start buprenorphine sooner, so there's some, it's called Bernie's method. Microdosing, I'll let the doctor talk more about that, because I am no doctor, but, there are some options there, and so I think just really, when you're thinking about what's the right treatment for you, I encourage people, I'm like, go check it out, go talk to a provider, you don't have to start treatment when you're with that provider, right? Like, you can go in and you can have some conversations and say, I don't know, maybe this isn't it for me, and that's okay. I think in this work, we do a lot of planting seeds. A lot of times we don't see folks in our offices until maybe 6, 7, 8 months, 2 years down the road. And that's okay. So I think just remembering that the first choice doesn't always have to be the right choice. And what didn't work for you 5 years ago may be great for you today, right? And so I think just keeping those things in mind.
I'm gonna echo all of those things, but the biggest message is there's no wrong door, especially in Summit County. So if someone's ready, just come in, or make a phone call to any of us. And if we're not the right place for you, we're gonna help you get to where the right place is. Just a great story with that. So we're literally across the hall from Porchlight. And so we had, one of our front desk reps came in and she said, I have a parent on the phone and their 30-year-old son is ready to get off of fentanyl and he's in withdrawal right now. What do I do? And I said, well, do we have anything available right now? She said, no, we're all of our providers that are providing this care. That's most of them are completely booked. There was like a 4 o'clock on a Thursday or something. It's always 4 o'clock, usually on a Friday, right? And I said, just put them on a hold, run across the hall and see if they can see this person. And they did. So, we work together. And I think the cool thing about having us all up here is now we're learning like, oh, okay, you can do that. We have nowhere to send people. So there's no wrong door. There's no wrong place to start. And so starting is the first step, is just making a phone call or coming in. So, I just want to echo too that, where to start too, again, different philosophies around behavioral health, what's involved, what's not. And I think all of our organizations now are kind of have the same philosophy around meeting people where they're at. And so, if behavioral health is what you need and what you're ready for right now, then we can provide that for you. If that's not what you need and you need primary care and you just need your medication, we can do that too. And so, and that goes for alcohol use disorder as well as opioid use disorder and other polysubstance use.
Kind of a good segue into my next question. Danny made the comment that a lot of mountain towns are drinking towns with a skiing problem, and that we're seeing more increased use of alcohol and stimulants. So what resources are there for folks dealing with those kind of addictions in Summit County? I know we kind of already talked about this, but I want to go back around.
So we treat all substance use disorders. So we're treating alcohol use, opioid use, and stimulant use disorders. There are FDA approved medications for alcohol use disorder. There are not yet FDA approved medications for stimulant use disorder, but behavioral health continues to be the, typically the best approach. However, there is a lot of opportunity in some off-label use of some medications. Our providers have seen a lot of success with the combination of Vivitrol and Wellbutrin for folks with stimulant use disorder. And so we're evolving there. We have a long way to go with stimulant use. I don't know that it's happening here. This is essentially incentivizing folks for engaging and being compliant with their treatment programs. And it's been proven to be really, really effective. And so we're starting to see more of that happen. I've seen the state is putting a little bit more money towards that as well. So that's an option too.
I think people very commonly think that syringe services are just for people who use opioids, and that's why I said, like, I don't really even like that term anymore, but you say harm reduction and nobody knows what exactly you're talking about. just kind of a way I sneak it into the conversation. But we absolutely provide services for people who use stimulants. We actually kind of steer away from only alcohol, but I always tell the hospital, just find out what else they use and then you can refer them to me. But we do the pipes and the safe snorting equipment. I actually think the safe snorting equipment is one of our, I anticipated it to be, and now we are starting to see it take off as one of our most popular services in our resort towns, because it's relevant to a lot more people, and a lot of different kinds of drugs, because we also continue to see the like mixed class drugs like MDMA and ketamine continue to be used a lot in our communities as well. And meth and cocaine continue to be large problems. And for me, really, the ability to offer somebody a pipe opens so many doors to treatment and access to care, because people's faces just light up and they're like, what did you just say to me? What are you gonna give me? And it can be controversial, but there is a disease prevention component behind providing these supplies that a lot of people don't understand, that there's commonly tears in the nasal cavities and mouth that can spread bloodborne pathogens and other diseases, but really just that rapport building. And I guess I'll say it now because I was reminded of it a moment ago that I forgot to say in my personal speech, that the game changer for me, I mean, there's so many things that go into it, but it's having people who love and care about me and people who tell me I'm doing a good job, and that belief that I can contribute to society, that I'm a part of society. And that's like an ongoing development for me. But, you know, I didn't really have that growing up. I was kind of more encouraged to use drugs and just be on that side of things. And just to have love and compassion and friends, that like we already said earlier, the key thing in addiction is having connection and having people who believe in you. And any one of us can be those people. But I think that also goes to how to support our loved ones, that it's so hard, but really just showing up and that unconditional love goes a long way.
Thank you. So as far as, we do offer behavioral health services, so, I'm a peer here at Mount High. Again, that just means that I have the experience, 9 years clean from my drug of choice this year, or this month rather. So a lot of that is, learning what addiction is, well, what addiction was for me. What that was, understanding that substance use is the secondary response to trauma, right? So once we were able to understand trauma and understand that, you know, the things that we experience in life lead us to, you know, substance use, it goes a lot with, being able to talk with therapists, which we have here, at Mount High. We also offer, mat services again with Porchlight, and then we also have peer services, which I do with some of the guys that I have. I'm real new to this field. I was a chef prior to this, so you know I'm still learning a lot from everybody here, but I would definitely say that once you start getting into that mindset of, you know, wanting to change, that there are those services like, you know, the MAT and peer services. We also look at LGBTQ plus populations as well. Yeah, so that's all I have right now.
Laura, you kind of alluded to this in y'all's presentation, but you mentioned that people with private insurance have high deductibles. That's often a barrier to accessing care. So what options do people have if they have those private insurance carriers or providers? They have those high deductibles. What options do they have to pay for MAT services or substance use disorder treatment?
Yeah, just because I'm holding it already. So we do have sliding fee scales available for folks, that covers their appointments. I also have some funding from the state of Colorado to support with medication costs. So, because sometimes that's where we run into issues, because we don't dose on site, we use pharmacies. And so what we often will do is we will use a sliding fee scale to cover their treatment. And then we'll use resources like the funding that I've got through some of the state entities as well as things like GoodRx, right, which provides discounted costs for medications. So typically what we will tell people, if finance is the only barrier to care, please still come and we will figure it out. We'll find out a way to do it, so.
We also have sliding scale. We have grant funding for people who don't have insurance or Medicaid eligible. So we do have a sliding scale. We are getting more grant funding to cover those who do have high deductibles and who are stuck in the insurance circle of. I won't go there. So we do, try to work with them. Again, don't not come to treatment because you don't think you can afford your deductible. And a lot of people don't realize, you know, they're spending out the deductible over here because their kids are in football and they're getting injuries and there's primary care visits and all that goes into the same pot. And so we continue to check insurance as people are in treatment with us to see where they are with the deductible, to see if we can work with them, while they're getting that taken care of and again, using grant funding.
So we're a federally qualified health center, so we have a sliding fee scale for all services, not just MAT services. And we also have our own pharmacy, which is super cool. So it's what's called a 340B pharmacy. So what that means is that for anyone who's a patient of ours in any service line, they can utilize that pharmacy and they can get very, very deep discounts on medications. And so it can make things very, very affordable on whether they have insurance or not. One of the coolest things about having that pharmacy within a MAT world is that there's zero stigma now. Now you're in the same doctor's office where you just saw your doctor, and now you just go to the pharmacy, pick up your medication with the pharmacist who knows you and has access to your record and has direct access to your doctor, which is really, really cool. Because there's, even for folks that are going out to pharmacies or sometimes like, you know, picking up their medications or, you know, trying to get refills on things, that can be really tough with some of the commercial pharmacies as well. And so that is a great, thing that we can offer that really cuts costs down, but also cuts down stigma too. Is there a question?
Also in
Karen?
rural communities, people know you at the pharmacy, right? They know your car, they know where you parked. So like, this is really a good option at the care clinic because you don't know if I'm here for my diabetes medicine, you don't know if I'm here for my fungal cream or my MAT medication, right? Like, mind your business. So I think that's a really great option that you all have as
Question out here.
So I just wanted to add a little more representation for the mountain community. I'm a Summit County native and been in and out of recovery, treatment, whatever, for 19 years now, exactly half of my life. I've got my 20-year high school reunion coming up in 2 weeks, and being here has just made me reflect on how many kids I went to school with that are no longer here. This is very much a escapist community that definitely has an alcohol problem. That was one of my main things. I can't speak so much to the opioids. But I just wanted to say, I'm glad that one of you finally said something about trauma. Because I understand that for a lot of people, medication is probably necessary. I've never been medicated. A few times I've tried it, hasn't gone well, reacted bad, didn't like the effects of it. But I was wondering, what all are you doing to get to the root cause of things as opposed to just put a Band-Aid on with medication? Because I know that there's a lot of research coming out lately about trauma, and not just personal trauma that you've experienced in your life, but generational trauma, past life trauma, if you believe in that sort of thing. Because I know for me personally, I felt uncomfortable in my own skin long before I ever took a drug. And I know that that's a huge reason why I started using in the first place, and why I kept continuing to use and relapsing over and over again, despite going through every treatment recovery option that is out there. And it's only through figuring out my own personal traumas that I've finally been able to truly heal and feel like I'm okay being me. So I just want to know, you know, what sorts of things are you guys doing to get to the root cause of things, other than just throwing medication at people. So, thanks.
It's a great question. So we actually, offer a lot of, trauma care as far as, getting to root causes and things like that. Our therapists are trained. So, well, we have 2 therapists that are on staff right. We're able to go ahead and, you know, walk that path with you as well. Again, we do voice and choice. So, if something's not working for you and you're like, hey, this is, you know, I feel like I'm getting here, you know, places on, with these, issues and not these other ones, and, you know, we could reevaluate and look at other options. But from what I've noticed, you know, we definitely delve more into the trauma side, just because that's, you know, historically speaking, those are the things that cause the wanting to use and things like that, so.
Same for us, we have the different levels of care within Denver Recovery Group, where we do have providers who provide groups around trauma. And they do things like DBT, and they do specific therapies that are effective with trauma and people with trauma. And trauma is identified, right? Some people have the big T's that everyone can see and hear about on the news, and then there's all the other small T's that build up over time and impact one person different than someone else. And so it's really important if someone wants to have any time of sobriety to really look at the recovery part of that and what is the root cause and when did this start for you. We have a lot of people that come and started experiencing trauma at 2 years old in the crib through their parents or other identified guardians. And so we always want to work with someone who's willing to spend the time. It can't be that in and out dose and go process and medication. That's not going to sustain long-term sobriety and growth and recovery and health and happiness. And so it's what we do is we really want to try to work with them when they're able and willing to focus on what has impacted them in their life that has resulted with where they are when they walk in the door.
So much to say. A lot of it's been said. Amazing question. I think Dana said it best. This is a symptom of underlying issues, right? Every psych book says that substance use disorder and alcohol use disorder commonly occur with like all these other disorders because that's how we're coping. That's how we're disassociating from that feeling of being in our own body. And that's why getting sober or whatever that looks like is half the battle, because now we have to learn how to be in our skin without that, which is still an everyday struggle. And so I just wanted to kind of describe a little bit more about why we do the work the way we do it in harm reduction, because it is my personal goal to be like 100% chemical free, or to the closest I possibly can be, which includes things like sugar. And it's like almost impossible in our culture. And when I tell the average person this, they're like, that's ridiculous. You're crazy. I'm like, you sound like my doctor. But you know, like full sobriety is really difficult for anyone to conceptualize. And so presenting it in that baby step model, you know, I can't put my goals or even my pathway on any other person. We're here to help guide people to what path is individualized and works for them. And that might change day to day, year to year, what works, what doesn't. But really, you know, giving that space and understanding that it can take a long time and that it might not ever be the goal, but that we're here to support you through whatever that process looks like, right? And I love to tell people this, that when people come to me for services, we ask, do you need Narcan? Do you need fentanyl test strips? Do you need pipes, syringes, hygiene, wound care, any of this stuff? That are kind of the basic stuff to address substance use. And then if the person hangs out and has time, the next question isn't really like, well, are you ready to get sober? Do you want treatment options? we like to ask a lot more questions to get to know the person and what are the root causes, right? So we want to know, what is your relationship with the legal system? Do you have health insurance? Do you have troubles with the legal system that we can help you with? Because those can be really like pervasive and pile on for like, even like a small ticket leads to fines, leads to more tickets. And it's just a vicious cycle. What is your housing situation like? Do you have safe access to food? Are you safe in your space? Are your roommates, are your family, are they safe people, right? And so really digging into these, like the social determinants of health, or the 8 dimensions of wellness, however you want to think about it, really kind of, it's pretty quick that you can start to see like where people are not having the best time in their life. And those struggles, those trials, I would say too, it's really easy to worry about one thing instead of 100 things. And so there's a lot of judgment in society of why a mom or somebody with a career, or these people with all these responsibilities would use drugs. And it's like, well, because that's a lot less to worry about than diapers and making dinner and making it to work and getting everyone everywhere they need to be. And so by having these real in-depth personalized conversations about like, who are you and what does your life look like? And I think everyone here does that in our own ways, helps us really get to like, what is driving the problem.
So we do not provide behavioral health services here in Summit County because our friends at Mile High do that. So we partner with them and let them do that. We do have psychiatric services, which can sometimes address folks who are maybe self-medicating. So, you know, sometimes you see stimulant use in folks who maybe have ADHD or ADD, right? So there's those sorts of things. But I think something to think about with when you're thinking about a harm reduction approach to treatment and harm reduction approach to care is, our chief medical officer says this all the time, what's the shark closest to the boat, right? And sometimes, yes, we know that trauma is the underlying key. And is there an opportunity for us to help you stop taking 100 blues a day so that you can find housing? So then once you find housing, then we can get you connected to behavioral health and say, let's actually talk about your trauma now that you are in a safe space and you have access to food and you have access to childcare. And so I think that's something that we have to think about often with a harm reduction approach to care is, it's really hard to ask folks to engage in addressing their trauma when they're still living on the streets, when they're still fighting for a meal every day, when they still don't know where their children are because they were taken away by a system, when they're facing a warrant tomorrow, right? And so I think there's all of those components and we have to, you know, follow the path that that's gonna work for them. So sometimes it's securing those basic needs. And then we can say, all right, now that you're safe, let's talk about all of these other things.
I would say we approach one, that's a big question, and there's not a easy answer. To try to do that would be to do it injustice, and so I would say we try to look at things through an integrated lens, and so everyone needs primary care, so everybody gets sick from time to time or needs wellness, and so anytime someone comes into our clinic, every single visit, they're asked, are you feeling down, depressed, or helpless? Do you still enjoy all the things that you like to do usually? Do you have concerns about your alcohol use, or just anyone else? Would you like to talk to someone about that? Every single time they come in. And so that's just becoming a norm, so that if someone is ready to talk about any of those things, then we say, okay, we're not going to talk about your blood pressure today. We're going to talk about this, if this is what you really want to talk about. And I'm going to bring my friend in here to come talk with you right now, if that's what you want. And they can either get you connected to a counselor, they are a counselor, or I'm going to get you connected to someone who's going to talk to you about your food insecurity, your housing issues, your, you know, and then really get you connected to all those places. And that's become just our normal process for every single patient. It takes more time, but it's worth it. And so how do we address that? All those traumas, I think it's just by asking and asking in a way that is normative, in a place that everybody has to go eventually.
question, because it's very fair. It does sort of feel like we're just throwing medication on something, Band-Aid. And I'll say being on the counseling end of things, it doesn't happen right away, and I have to definitely build trust. Our patients will not talk to me. Am I not right? So you have to really they have to buy in that you actually care about the questions you're gonna ask them. And especially in the LGBTQ, I have personal experience, sorry. That's a difficult area, very, and if you are not gonna trust the person that you're talking to, we're never gonna reach your trauma. And it's, sometimes the medication helps because you come out of your skin without it. At least, you know, okay, get it, just making sure you're okay with it, but, I guess the question would be more to you, like, what would you prefer someone to say to you to help you on that journey? That would be something I would like to know.
Yeah, and I guess when I was asking the question, I was asking more like, not just like initially like, okay, this person's just now trying to get sober, like obviously you gotta deal with first things first. But you know, you want to get, I'm with you, like I'm trying to lead like a completely clean life. I've tried to quit coffee, I don't know how many times, but I've been a barista most of my life, so you know, good luck with that one.
We're drinking in a liquor store, so.
Yes.
Same.
I guess just, yeah, going into your history, like why, what makes you feel so uncomfortable? Like what makes you feel the need to use? Why did you first start using? Because, you know, a lot of people, they start off with pain pills, but not everybody gets addicted to pain pills. It's an underlying trauma issue. And a lot of times it's not obvious trauma. It can be a lot of generational trauma. It can be things that your parents and your grandparents dealt with. For me personally, I have a lot of trauma related to getting kicked out of your home, and not like your house home, but like your home. Summit County is my home, and I have this big feeling that I'm just like, I'm getting kicked out of here because it's the cost of living and affordability is just astronomical right now. I've been off and on homeless for a few years. My current living situation is not ideal. And, you know, it goes back to my grandparents in World War II were moved from Lithuania. And then both of my parents have basically been forced out of their home when they were younger. And so it's just things like that, I guess. Yeah.
You asked the
I
right
have
question.
a lot of experience in the therapy treatment recovery, so I'm not shy about opening up to any random person. And I'm probably on the spectrum, so you know.
Can't lie.
Well, respect everyone's time. We're gonna cut it off. That was couldn't think of a better way to end tonight. That was awesome. Thank you to all of our panelists. Thank you everyone for joining us tonight. Thank you, CNC, for having us, and everyone get home safe. Thanks for being here tonight. Let's hear from Maggie, who's a peer for Hierarchy Harm Reduction.
Thank you so much. Hi, I feel really weird having this upbeat personality right now, but I can't fight it, and I'll talk about that a little bit. Hi, I'm Maggie Saldine, happy to be here with y'all tonight. So many awesome, familiar faces and colleagues. For those of you who don't know me, like Dylan said, I'm a peer at Hierarchy's Harm Reduction. I'm also the founder and director, and we provide evidence-based programming for people who use drugs and their friends and family here in Summit, as well as Eagle, Lake, Garfield, and Pickens County for now. So hopefully we can connect after this too. But today I'm here to talk a little bit more about my personal story, which I am very public with, but I don't always lead with or really talk about this stuff as much. So super honored to be invited to represent myself and the people that I love with that story tonight. Or some of it. I grew up in Carbondale, which is about 2 hours away from here, but very similar. Small, rural resort, a little bit of agriculture, a lot of Spanish speaking, some art too, a little bit of everything. But a lot of drug use, a lot more than people seem super willing to talk about. And while I can't represent Summit County as well, I think my story is one that we see over and over again, that's often underlooked or overlooked, and not everyone has the, I wouldn't call it courage. I don't know what it is that drives me to be able to do this, but not everybody can do it. So I just really think it's important to share how real these stories are in our rural communities. I am very public about the fact that I lost my mother to a heroin overdose when I was 15 years old in 2006. You don't have to do the math. I'm 33 today, 34 next week. And I think that's a really important thing for people to know about me, but not because I want pity or even sympathy or anything like that. But to me, it kind of explains what my childhood was like. That the overdose death alone was only one trauma in a sea of episodes. When my mom passed, I was 15. I was injecting heroin, smoking meth, snorting cocaine, pill shopping from hospitals and doctors, pretty much whatever I could get my hands on to disassociate. And my mom's death was in a lot of senses a blessing for me, because it was the thing that really allowed me to escape that cycle of drugs and addiction and violence that many of us struggle with and many families are still stuck in today. I now have 5.5 years of sobriety from alcohol, but that didn't happen overnight. But there was a lot of turning points in my life that on paper looked very negative, death, divorce, moving, that really made me stop and think, well, what am I doing? And I think a lot about what that 15-year-old girl was gonna do with her life before my mom passed. Because she didn't have a lot of options in her own mind. And it was a long, long journey to that day to today. And I believe that getting sober is only half the battle. That getting free from our substances of choice is a huge, huge, huge difficult thing. And it's only part of it. And it's kind of a tool that allows us to do the real healing and the real deep diving. I think it's interesting to note that I never really had a problem putting heroin or cocaine or meth, but alcohol and still today nicotine and some other things have been a lot harder. A lot of that goes to cultural acceptance, but addiction is a funny thing and it latches on in different ways for different people. I believe in harm reduction because it's what saved my life. It's all about baby steps. And I didn't decide to quit drinking one day and that was it. It feels like that sometimes, but it was a long progress. I love to tell the story. I quit drinking hard liquor and then this is kind of dating myself. I quit drinking Four Locos, which back then had a lot of caffeine and a lot of sugar. And so I quit drinking hard alcohol. I quit drinking Four Locos. I quit using cocaine. I quit drinking hard alcohol, I quit drinking Four Locos, and I quit using cocaine again. And it was a cycle, and I still see people in that cycle of trying to figure out where it works for them. For me, alcohol is not a part of the solution. It's most of the problem, and it was for my mom for most of her life. But now we're seeing things like we know from a lot of empirical evidence that things like methadone are the gold standard, and having these things in our community is gonna make such a huge difference. I'm so excited about the work being done there. But we're starting to see advances legally and psychologically and medically in plant medicine. In the 5 years since I quit drinking, I have been put on ketamine by doctors, which was a hard choice to figure out how that worked in my recovery process. But I don't know any doctors that think I shouldn't be medicated or partially sedated. And figuring out how that works for me, how to use medications to my benefit, because there's a lot of options out there. Some things work for some people and others work for other people, but I think that having this greater acceptance around all the pathways is gonna save a lot of lives. Because Suboxone saves lives, methadone saves lives, and now we're seeing ketamine, psilocybin, MDMA, and ibogaine saving lives. And sometimes that's hard to digest, but we just have all the options, and we want to have all the options because we have all the people, we have all the economic backgrounds, all the lifestyles in our Rocky Mountain towns. And so I'm excited to see us have all the options. Thank you for having me. I think that's enough for now, but so happy to be here.
Thank you, Megan.